Hello again, fifth year medical student, Miss University Medical College. We continue our lecture about thrombotic disorders, and the topics to be continued is antiphospholipid antibody syndrome. This is nowadays is commonly seen in clinical practice, and usually it was previously not detected and not known as a disease as such, but nowadays we face a lot of cases underlying these topics. So what is antiphospholipid antibodies? These are either anticardiolipines, antibodies to beta-2 glycoprotein 1, or lupus anticoagulant. So anticardiolipine and or anti-beta-2 glycoprotein 1, lupus anticoagulant, 25, 50% of the patient, 50% having positive test for these antibodies, and thrombotic manifestations of antiphospholipid antibody syndrome. Venous thrombosis more commonly than arterial, so it can cause both venous and arterial. Venous thrombosis most common in the calf, arterial thrombosis most common in the cerebral circulation. Elevated anti-beta-2 glycoprotein 1 antibodies, and this is the endothelial surface. These are antibodies, and these antibodies attached to the glycoprotein beta-2 glycoprotein 1, and these antibodies causing destruction of this endothelial surface, and this destruction enhance thrombus formation. Incidence of antiphospholipid antibodies in general population is about 3 to 5%, with an increased frequency in older population. Recent infection 30%, HIV 20 to 42%, SLE about 18 to 86%. So false positive test can be seen in general population, especially in elderly. What are the criteria for diagnosing antiphospholipid antibody syndrome? We have clinical and lab criteria. Clinical criteria is very important to be considered here. Any adverse pregnancy outcome, recurrent first trimester abortion more than 3, so it is recurrent consecutive first trimester abortion more than 3 abortion, unexplained death of morphologically normal fetus after 10th week of gestation, severe early preeclampsia first trimester, venous thromboembolism, arterial thromboembolism, livedo reticularis, discoloration of the skin, mainly in the lower limbs, catastrophic antiphospholipid syndrome, transverse myelitis, skin necrosis, and chorea, abnormal movement. Condition, dataset secondary cause of APS, SLE, rheumatoid arthritis, systemic sclerosis, Behçet syndrome, temporal arthritis, and Sjogren syndrome. Tested to be sent, lab criteria, beta-2 glycoprotein 1, protein C, annexin 5, prothrombin may result in hemorrhagic presentation. So we need one clinical and one lab in order to diagnose antiphospholipid antibody syndrome. One clinical, one of these, and one lab. Next, current therapies for antiphospholipid syndrome include the following medications. So after diagnosis, what about the treatment? Heparin, low molecular weight heparin, unfractionated heparin, warfarin, antiplatelet agent, aspirin, clopidogrel, hydroxychloroquine, lifelong anticoagulation for the antiphospholipid syndrome. Catastrophic antiphospholipid syndrome is a rare, potentially life-threatening and fatal condition characterized by widespread thrombosis, affecting most of the organ of the body, especially brain, liver, heart, lung, spleen, etc. It is treated with early and aggressive therapy that include anticoagulation, steroid, and in severe cases they might need plasma exchange and IVIG. Who need to be tested? It's very important topics. Who need to be tested? Initial thrombosis occurring prior to the age of 50, family history of venous thromboembolism, recurrent DVT, thrombosis occurring in unusual site, like portal vein thrombosis, history of warfarin-induced skin necrosis, suggestive protein C deficiency. So whenever you start warfarin, the patient develops skin necrosis, a side effect of warfarin, displaying that the patient having protein C deficiency, which is a risk factor for thrombosis. For patients with VTE who have one first-degree relative with documented VTE before the age of 45, we suggest testing for all 5 inherited thrombotic disorders mentioned previously. For patients with VTE who are less than 45 and old, we also suggest testing for all 5 inherited thrombotic disorders. And patients with first episode of unprovoked VTE, so there is no risk factor for VTE, we suggest limited testing for cancer screening. In patients with recurrent thrombosis, multiple thrombosis, and thrombosis unusual vascular bed, hepatic thrombosis, portal vein, we suggest testing for inherited thrombotic disorder, antiphospholipid antibody syndrome, and malignancy, JAK2 mutation for myeloproliferative disease, and paroxysmal nocturnal hemoglobinuria. Patient with arterial thrombosis, we suggest testing for marker for antiphospholipid syndrome and testing for malignancy. For patient undergoing testing for hypercoagulable disorders, we prefer that all tests be performed 2 weeks before the discontinuation of anticoagulation whenever possible. For patient undergoing testing for malignancy, we prefer limited strategy rather than extensive strategy. In patients with VTE who have history of warfarin-induced skin necrosis, we suggest testing for protein C deficiency. In certain high thrombotic risk situations, screening for inherited thrombophilia, if present, may promote consideration for prophylactic treatment or alternation in the type and duration of antithrombotic prophylaxis. These scenarios include presence of homozygous for factor V Leiden prothrombin mutation, inherited vitamin K, initiation of vitamin K antagonist in patient protein C deficiency, giving potential for rare complication of warfarin-induced skin necrosis, consideration of antithrombin concentration, administration in antithrombin deficiency in the peripartum period in pregnant women, or in conjugation with surgical procedure where anticoagulation cannot be safely administered. We typically do not screen women taking oral contraceptive for inherited thrombophilia unless the first degree relative has inherited thrombophilia and clinical thrombosis. This means that patients with pregnancy and develop DVT after delivery, there is obvious risk factor like pregnancy per se, protein S deficiency, anesthesia, bedridden, surgery by itself causing protein S deficiency. So whenever they have obvious risk factor, no need to test for genetic cause unless there is positive family history. What about the decision to anticoagulate indefinitely for life? First episode of DVT without provoke cause, proximal DVT. Whenever we say proximal, it is above knee. Any provoked pulmonary embolism or active cancer. Whenever you have cancer, there is risk for thrombosis during whole course of treatment of cancer. So we should continue anticoagulation. Indefinitive anticoagulation should be also routinely administered to patients with provoked episode of VTE with major transient risk factor, surgery, cesarian, cessation of hormonal therapy. It's very important risk factor. For most patients with recurrent provoked VTE or first episode of provoked VTE with irreversible, multiple, or minor risk factor, therapy must be individualized based upon careful assessment of patient-specific risk of bleeding and thrombosis. So this is decision by physician. Factor that affect bleeding risk, elderly age, frequent fall, patient value, and preference, burden of thrombotic monitoring strongly impact the decision to continue or discontinue anticoagulation beyond the conventional period. Let us say rural area, you need to assess PT and PTT every 21 days. It's difficult for them to be in contact with you and to do these lab tests. So here you have to decide to change the type of oral anticoagulation. Most patients who is choosing indefinitive anticoagulation continue their current anticoagulation rather than switch to a new agent. However, alternative agent may be need to initiate for a variety of reasons during therapy. let us say side effect, inavailability of a drug, we can change the oral anticoagulation like warfarin to dabigatran, unless you have no other choice. For most patients, we suggest full intensity anticoagulation with INR ratio 2 to 3, never below 2 or above 3, because to decrease the risk of bleeding. Below 2, risk of thrombosis increase, above 3, risk of bleeding increase. However, aspirin may be prescribed to those who decline anticoagulant therapy provided there is no contraindication. Aspirin may be prescribed for those patients who are not fit for anticoagulation, fragile patient, elderly patient, patient with comorbidities, patient with a lot of medication and risk of interaction between other drugs. When not to test, protein C deficiency, protein S deficiency, antithrombin deficiency. These assessment or the test for these deficiencies should be assessed waiting at least 1 month after stopping their medications, their anticoagulant medication. Anticoagulation in a special situation, thrombocytopenia, specific cancer, massive pulmonary embolism, comorbidities, liver or renal disease. We should have to consider alternative to heparin in this situation. Specific cancer, low molecular weight heparin superior to warfarin, massive pulmonary embolism, heparin with high dose, let us say bolus, then maintenance, we need rapid action. And thank you for listening, and I am happy to answer any question from you. Have a nice day. Thank you.